Good evening, everyone. Welcome to tonight's webinar. My name is Renee De Silva, and I would like to welcome you all to the second webinar in Move Muscle, Bone and Joint Health 2016 Community Webinar Series. Tonight's webinar is on the role of exercise in the prevention and management of osteoporosis. Before introducing our presenter for tonight, I just have a couple of housekeeping issues to run through with you. Firstly, if you have any technical difficulties during the webinar, please refer to the message box on the left-hand side of your screen. You can type a message there at any time, which will be read by the webinar organizer at Redback Conferencing. If you are listening via the phone, you will notice a small time delay between the audio and the visual. You can type a message at any time you will notice a small delay between the audio and the screen. That is quite normal, so don't be concerned. Also, whilst our presenter will aim to answer questions at the end of the webinar, please type a question at any time. You will notice a small grey box on the left-hand side of your screen. Type in a message there. For example, I will type a question now and push enter. So you will see that on the left-hand side of your screen. So don't leave it to the very last minute because we will aim to finish at 8 p.m. I would also be grateful if all participants could take a moment at the end of the presentation to complete a small exit survey, which should only take about 30 seconds to complete. So our presenter for tonight is Professor Robin Daly. Professor Robin Daly holds the position of Chair in Exercise and Ageing within the Centre for Physical Activity and Nutrition Research at Deakin University in Melbourne. He has over 20 years of experience in conducting human, clinical, public health and translational intervention trials to evaluate the role of exercise and nutrition for preventing, managing common chronic diseases such as osteoporosis, sarcopenia and falls. He has been an active contributor nationally and internationally to clinical guidelines in the area of exercise, calcium, vitamin D for osteoporosis prevention. He is a Fellow of Sports Medicine Australia and is a member of the Medical and Scientific Advisory Committee of Osteoporosis Australia. He is also the founder of the Osteocytes Strong Bones for Life, community-based osteoporosis prevention, exercise and education program. So without further ado, I'll hand this over to Rob. Thanks very much, Rob.
Thank you, Renee, and good evening, everyone, and welcome to this webinar, and I hope you will enjoy this particular session on exercise for the management of osteoporosis. It's very much a practical seminar, and it certainly aligns with today's initiatives, I guess, which is the World Osteoporosis Day. So please feel free to ask questions towards the end of the seminar, but as I mentioned, this will be hopefully give you some practical tips and guidelines about how you can really optimize your bone and muscle health to reduce your risk of falls and fractures. So for many of you, I guess you would wake up in the morning and you might look in the mirror and you look at yourself and you worry more about perhaps what your appearance would look like than what actually might be going on inside your body. And so for women, they might be worried about their wrinkles. And if we look at your typical male, he might be concerned about his body shape or size. But if you actually have the opportunity to look inside your body and specifically looked at your bones and you saw something like this, you might be a little bit concerned. Now, unfortunately, osteoporosis is one of those diseases where it's really a silent disease. You don't really know that you've got osteoporosis or you've got low bone mass until you really have a fracture. And fractures are the end point for osteoporosis. And that's really what we're trying to prevent. So even when we look at pharmaceutical agents or lifestyle factors where we're trying to optimize our bone health, what we're really trying to do is prevent our risk of having a fracture. Because just having low bone density, there's no signs, there's no symptoms, it's generally not harmful. Even if you've got osteoporosis, you're not necessarily going to have a fracture. It just means you're at increased risk of having a fracture. And so for some of you, you may be surprised that a large proportion of women, and as this slide shows you, at least 30 to 50% of women aged over 60 that have a fracture don't actually have osteoporosis. So they may have what we call osteopenia or low bone mineral density. So osteoporosis per se is not really the problem. The problem is having a fracture. And we know that the fractures are the cause for all the concern in terms of the long-term consequences in terms of your health and well-being. And the reality is fractures can occur to anyone. And I'm guessing many of you will recognise this particular person, David Parkin, who's a spokesperson for Osteoporosis Australia, and today highlighted that he was diagnosed with osteoporosis several years ago after he had a fracture of the spine simply walking or running down a flight of stairs here at Deakin. And I spoke to David not long after he sustained his fracture, and his initial thought was when he had a vertebral fracture was that he was having a heart attack. And he went through multiple tests and screening, and it was finally diagnosed that he'd actually suffered a vertebral fracture. And then he got diagnosed with osteoporosis. So we know osteoporosis affects both men and women. It's about 1 in 2 women over the age of 60 compared to 1 in 3 men. But it's really fractures what we're trying to prevent. And there's good reason why we're trying to prevent fractures. And here's some quite alarming statistics which many people aren't really aware of. But for those that have a hip fracture, and hip fractures are probably the most devastating of all the fractures, we know that about a quarter of people will die within the first year. Now, they don't die from the fracture per se. They generally die from the complications associated with a fracture. And you can see here, often fractures lead to permanent disability, inability to walk independently, which can obviously have an impact on your quality of life, difficulties with normal activities of daily living. That's what the ADL stands for. And so you can see the consequences of a hip fracture in particular are quite devastating. But, an early sign of having a risk or being at risk for osteoporosis or fractures is you might suffer a wrist fracture. So many women in their 50s, between the ages of 50 and 60, might suffer a wrist fracture. And often, they'll go to their doctor and the fracture, they'll get a cast and it'll get healed. And the doctor won't even think that they might even have osteoporosis. They might just think they fell over and had a wrist fracture. But that should be an early warning sign that there might be something wrong with your bones and that you might need to get further follow-up. So the other important point to bear in mind is that we know our muscles are connected to our bones. And we know that as we get older, the size of your muscles decrease substantially. So this picture is a nice picture of an MRI scan. So an MRI signals the different, gives you different pictures of your muscles and your bones. So in this case, the bone is actually black and the marrow inside is the yellow part. Here's your muscle, here's your fat. So you can see from about the age of 50, or 45 to 50, that's when we start to lose our muscle mass and our muscle strength. And by the time you get to 70, or if you're bedridden for a certain period of time, or you've got a spinal cord injury, you can see you lose substantial amounts of muscle. But in addition, you get this fat infiltrated within the muscle itself. And so it's like a good quality steak where you get a nice lining of fat, which might taste good from a food point of view, but for your health and well-being, it's really quite detrimental. And we know lots of fat within the muscle not only is bad for your overall health and well-being, but in terms of cardiometabolic health, cardiovascular disease, type 2 diabetes, but it's also associated with an increased risk of impaired muscle function. So maintaining your muscle mass is absolutely vital as much as trying to maintain your bone mineral density. So the reason for this is we know that most fractures are due to falls. Now this looks like a complicated slide, but essentially what it's showing you is a group of people who had different levels of muscle function. So the chair standing test, for example, if you were in this Q1 column, you had really good chair standing ability. You could do it quickly. If you were in Q4, you had the poorest level of chair standing ability. And the same applies to leg strength, gait speed, or grip strength. So what you can see here, for those in the who had the poorest muscle function, they had about a 2 to 3 or 4-fold increased risk of having a hip fracture, regardless of what their bone density is. So just keep that in mind. People know that bone density increases your risk of having a hip fracture. But this shows that if you've got impaired muscle function, it doesn't matter what your bone density is, if your function is really poor, you have an increased risk of having a hip fracture. So that is really important when we think about exercise or lifestyle factors, how we can optimize or reduce our risk of having a fracture. We need to think of the bone, but we also need to think of the muscle because most fractures, especially hip fractures, result from a fall. So Currently, there's this concept called sarcopenia, and sarcopenia basically means age-related muscle loss and impaired muscle function. And so in the clinical field, you know, when you go and have your bone densities, when you go and have your risk for osteoporosis assessed, you might have a bone density scan. So we're moving now to these algorithms or tests which we can try to assess your risk of having sarcopenia or impaired function. And one of the tests is looking at gait speed, so how quickly you can walk over 4 or 6 meters. And if you can't do this when you work it out per meters per second, if you're less than 0.8 meters per second, you're classified as having impaired function. Now, in a research setting and in the clinical tool, we sometimes use grip strength as well, which is a measure. And if you have a DEXA scan and you have a total body DEXA scan, again, we can look at how much muscle and fat you have in your body. But for most of you, these tests are not readily available and they're not part of routine clinical practice yet, but we're moving towards trying to get these additional tests when you have your DEXA scan to look at muscle function as part of routine screening. But for most of you, you can do some other simple tests as well. First of all, you can ask yourself this question, or your doctor might ask you this question: have you had a fall recently, or are you worried about falling? If you answer yes to that question, it may mean that you're at increased risk of having sarcopenia and increased risk of having a fall and fracture. Because we know that people who have one fall are at certainly increased risk of having subsequent falls. So if you're a faller, you need to think, what can I do to reduce my falls risk? And there are other very simple tests which you could all do now, essentially, is do a sit-to-stand test. So essentially you sit on a chair and you sit and stand 5 times as quickly as you can. And if you can't do it within 12 seconds, it might be some sort of indication that you might have impaired function. And again, for recurrent fallers, it might be a 15-second cut point. Now, there's other protocols like the 30-second sit-to-stand, and we've got some normative data here you can see in this little table. So if you're age 70 to 74 and you're a female and you can't do 14 sit-to-stands in 30 seconds, it might be partly indicative that your function might be starting to wane. So these are very simple tests that you can do, and they're only indicative or give you some sort of indication of whether you might be sort of leaning towards the sarcopenia impaired function category. But there's certainly something that you should also look at in addition to your bone density test if you've had one. So I guess what we're here tonight to really learn about is exercise and what type of exercise is optimal. And you've got a whole range of options that you can choose from. But we generally know from musculoskeletal health, bone and muscle health, that not all forms of exercise are equally effective, and some are better than others. But first of all, I would just want to highlight that any exercise is good for you. So you'll hear in this presentation, I'm going to talk about specific modes of exercise which are particularly good for bone and muscle health. But not everyone can engage or will want to engage in these types of activities or exercises. But this particular slide just shows you your risk of dying in this vertical y-axis here versus how many hours of exercise you might do per week. And the point I really want to highlight is right at the top of the graph here is this slope here, which basically highlights for people that do nothing and then just start to do a little bit, so an hour per week, you can see you get really rapid improvements in terms of reducing your risk of death. And so that's my point here, that just doing something is better than nothing, but if you start to do a little bit more, you'll gain some additional benefits. So even though my guidelines or slides will highlight specific examples of what you should be doing, if you're not doing anything, start by doing something, because you will see some health benefits. But what I'm really going to highlight in this presentation is what you can do which is going to be optimal for your bone health. Because what is good for your heart might not necessarily be good for your bones. So the first important point I want to highlight is that bones like stress. They like to be strained or stressed on a regular basis because they will adapt to the stress that you impart upon them. So here's a classic illustration of what happens compared to a normal bone that undergoes daily loading compared to one where you take away all the loads as if you were bedridden for a year or you went up into space for a year and you didn't do any type of exercise. So you can see here in a growing bone or an older bone, if you look at the older bone as an example, basically you start to lose all the bone from the inside. So it's what we call endosteal bone resorption. So the thickness of the bone, the cortex, becomes much thinner because of disuse. So the important point is that bones like stress. The big question we always get is, does exercise, if you undertake it regularly, reduce your risk of having a fracture? And this is really the $100,000 question, and that's what all the drug trials are based upon. They give people drugs and they look at whether they reduce a person's risk of having a fracture. Now, unfortunately, most of these trials require thousands and thousands of people, and so no one's ever funded a really large trial or study to definitively conclude that exercise will reduce your risk of having a fracture. But there have been a number of individual studies which have looked at the effects of exercise on bone, and then they've looked at whether a person or groups of people within that study have fewer fractures compared to those that don't exercise. So here are a whole lot of individual studies. You don't need to know the detail of this particular little figure, but what this particular paper showed was that people who undertook regular exercise had about a 50% reduction in their risk of having any type of fracture, and it was about 44% reduction in vertebral fracture. So it's sure the level of evidence to support this study is not as strong as perhaps, for example, a drug trial where it's very controlled and everything is in place like a proper clinical trial. But it certainly highlights that exercise can reduce your risk of having a fracture. Now the big question is, what type of exercise is best? What should I be undertaking to reduce my risk of having a fracture? So often you might go to your doctor or another health professional, and they'll look at you and you might talk about your bones and say, look, I'm a little bit worried. My mother had osteoporosis, had a fracture. I want to be, trying to reduce my risk, and I don't want to take drugs. And your doctor or some health professionals will say, well, you need to be more active. Now, that's true, but it's not particularly informative. So we need to get to more prescriptive or evidence-based prescription for you to for you to be able to undertake an exercise program that is really going to have the biggest benefits for your bone and muscle health. Simply telling you to be more active is not informative. If you, for example, decide, I'm going to swim a little bit more, we know swimming has very little influence on your bone density or bone health. So another common activity which most people undertake, and they think it's fantastic for your bones, is walking. Now, I'm a strong advocate for walking because I think it's great for your cardiovascular health. It's easy to do. People can get outdoors easily, and it doesn't require any equipment. But the reality is walking typically does not have any beneficial effect on your bone health. And in fact, a number of years ago, we did a large study looking at the effects of walking in a whole lot of Australian older adults. And what we found, to our surprise, was basically that adults who walked more tend to have an increased risk of having a fracture. Now, that might be a little bit alarming, and but other studies have also shown that people that walk more at increased risk of having a fall as well. And that's probably not surprising, given that if you're going to walk more, you're outdoors more often, you're walking on pavements or footpaths where you might increase your risk of having a trip and potentially a fall or a fracture. But my point here is that we know walking is not really a sufficient activity to load the bones over and above what they're usually accustomed to. And that's why it generally doesn't have a big effect or a large effect on improving your bone density. There is some evidence that brisk walking or hill walking or walking with a weighted vest or walking in combination with some other exercises is effective, but just simply undertaking a regular walk on a daily basis is probably not going to improve your bone density. And some of you might ask why. How is this the case? Well, for many of you, you won't ever seen a picture like this, but this picture is basically a zoomed-in picture of the cells inside your bones. And these little black cells here, with all these finger-like projections, are what we call osteocytes. So they're bone cells, basically. And traditionally, many people thought, well, these osteocytes serve really very little function. But we know that they are the bone-sensitive cells. So they're the cells in your body that tell the other bone cells to either build bone or take away bone. So they are the strain-sensitive cells. And you can see they are connected to one another, and they're also connected to the bone surface here. And so as I've said in the little blurb down the bottom there, osteocytes are fabulous gossipers if you arouse them. So you've got to think your bones are alive, they're active, you've got to stimulate your osteocytes. So you've got to do activities where these little guys are going to think, hang on, what's going on? I need to send signals to my bone cells to start forming more bone, otherwise I'm going to have a fracture. And so if you can think about these little osteocytes, perhaps when you're exercising, and say, I want to arouse you guys so you can stimulate bone. So what works? Well, this is a bit of a summary of where we currently sit in terms of what exercise is optimal. So we know that moderate to high impact weight-bearing activities, jumping, skipping, hopping, are really good for improving your bone density. Sure, not everyone's going to be able to do those activities, but the evidence tells us that that is really good because those activities will stimulate bone cells to adapt. We know that resistance training, lifting weights at a relatively moderate to high intensity, as long as it's progressive, is also effective. But I'll show you some evidence at some slides later. The evidence is somewhat mixed, and I'll explain why. And probably the best programs are those that are multimodal. So those that include a bit of a combination of resistance training with these weight-bearing activities and probably balance and challenging activities to reduce your risk of having a fall. So the big question we get, well, how much exercise do we really need to do? So just to give you an example of weight-bearing impact exercises, here are some activities that we did in a number of studies in older men and women. And these are the types of activities they were prescribed. So you can do marching on the spot, side-to-side shuffles, little pogo jumps, and some people even progress to stepping off a box. Now, all of you are not going to start on these activities, and typically we don't prescribe any high or even moderate to high weight-bearing activities at the start of your exercise programs. We usually encourage people to try to improve their muscle strength first, and then they slowly progress to these weight-bearing impact activities. But you can use your imagination about any types of weight-bearing exercises, but if you haven't exercised for a while, don't start with these activities. Try to build your muscle strength a little bit, and then you can progress slowly to a few jumping activities. Now, importantly, you don't need to do a lot of jumps. So again, this is a bit of a scientific slide, but if you look at the graph with the green bars on them, this was a study we did in older men, and they did resistance training with some jumping activities. And at the end of the study, we went back and we looked at, well, how many jumps on average did they do throughout the whole study, and was there a relationship between the number of jumps and their change in bone density? And what you can see here is this perfect dose-response relationship. So this was a no exercise group, they lost bone, but those that did 30 and then greater than 50 jumps had a greater response in their bone density. 50 jumps 3 times per week over an 18-month period. I'm sure many of you could easily adopt that type of program. So that's essentially, while the kettle's boiling, you might do some mini steps or jumps or hops, and you might do a set of 10, have a bit of rest, do another 10, and then do another 10. And then over time, you might eventually do, progress up to 20. It's not a lot of jumps to stimulate your bones. And this other study shown in the blue bars basically looked at how often do you need to do jumping. And so they had these group of women jump on one leg, which is a bit of a strange program, but their one leg served as the exercise leg, the non-exercise leg was the non-jumping leg. And so one group jumped 7 days per week, one group jumped 4 days per week, one 2 days, and one did nothing. So what you can see, the 7 days per week clearly had the biggest benefit, but there was no difference between the 7 and the 4 days, which is consistent with a lot of our guidelines suggesting that probably jumping 3 to 4 times per week, and it might only be 50, I'm not saying 50 is the magical number, but say somewhere between 50 to 100, 3 or 4 times per week might be a strategy to help maintain your bone density. The other important point to remember is you don't have to do high magnitude jumps. Remember, bones like strain, they like stress, and they like to be stressed in different directions. So again, this was another study where they had adults do multidirectional jumping on one leg, and the other leg served as the control. And all they did here was 5 times 10 lots of jumps. So 50 jumps was over a 12-month period. That's all they did, and they were multi-directional. And what you can see, they took these fancy scans where anywhere you see a blue or a green colour, that means an increase in their bone density. So you can see here in the exercise leg at the hip, they improved their bone density around the femoral neck or the hip region here and all the way down into the lower part of the hip. For those that were the control groups, you can see the benefits were nowhere near as beneficial. So they loaded the hip with exercise and they got site-specific adaptations at very important regions in the hip, which I'll explain shortly. So exercise works. And just as a bit of a comparison, here's a study looking at the same types of scans where they gave them drugs. It was a drug treatment study. You can see here, exercise really didn't result in a lot of improvements in the cortical bone, the outside bone, in the hip region here, or cortical thickness. So giving people drugs, might result in a sort of a generic improvement in their bone density, but it might not improve the bone density at specific regions where you need it the most. Now, just to illustrate this point, here's some nice little pictures of the bone thickness in your hip. So if you can see the slide here where the red and pink regions, that means the thickness of your bone is really thin in the green, in the red or the pink regions, and it's thicker in the blue regions. And so what you see, if you look at the cross-section through the hip, you can see your femoral neck in particular is really thin, especially up the top part of your femoral neck. It's millimeters thin, okay? And when you fall sidewards, all the stresses on the hip occur in this top region, and that's the thinnest region, okay? And we know that women who have a hip fracture have this area of weakness right here where the bones are the thinnest and the weakest, and that's why they're prone to fracture. And if you think back to my last slide, where the exercise program had specific benefits right through this region where you need it the most. Whereas if you take drugs, it didn't actually improve that region. So exercise results in very site-specific benefits if you do the right types of exercise to load those regions of your hip or your spine or your forearm, whatever the site may be. Obviously, another type of activity which is very common is resistance training. Now, unfortunately, if you look at the evidence for resistance training, it's really quite mixed. And part of the reason is there's a lot of variability in the type of resistance training programs. And so this is just a bit of an illustration to show that, these people are trying to exercise to improve their bone density through elastic bands, and they're seated. So you can clearly see that this is going to have no benefit on their bone density in the hip or potentially their spine. Okay, so clearly we need targeted exercise. And so when you look at the studies which have looked at the effects of resistance training, lifting weights on bone, many of the programs are really not effective because they have a poor training dose. In other words, the weights are just really light and they're not progressive or intense enough. So the other point there, second one, lack of progressive overload. So when you undertake resistance training, it's got to get a little bit harder over time. You can't go lifting the same 2 kilogram weights just for a year and expect to get an improvement. Your body will adapt really, really quickly, and so you've got to slowly progress over time. And the other point, which I highlighted in the last few slides, is the concept of specificity. So if you're undertaking a resistance training program, make sure you've got exercises which are specifically designed to load the muscles around the hip and the spine and, say, the forearm, particularly if you're worried about a forearm fracture. So exercise, specificity, progressive overload are key elements of any program. Now, many of you may be a little bit concerned about undertaking resistance training, but resistance training can be undertaken safely pretty much by anyone. And just to illustrate this point, here was a study which was done in 100 frail nursing home residents. Their mean age was 87. There were some people who were aged 100, and they undertook resistance training 3 times per week. And you can see that these two groups who undertook the resistance training program got, up to 100 or over 100% improvements in their muscle strength. Anyone can safely undertake resistance training. I'd strongly recommend some guidance on supervision on how to lift a weight correctly. But one of the benefits of resistance training is once you undertake it, you will see improvements drastically within the first couple of weeks. You'll feel better, you'll feel stronger, and then over time, if you continue with it, it might help improve your bone density. Just to give you an illustration of the concept of specificity in terms of targeting specific regions to reduce your risk of having a fracture. Here was a study where they had women do back extension exercises. They wore this little weighted pack and they lay on the ground and did 10 repetitions at home 5 days per week for 2 years. And this top graph shows you their improvements in their muscle strength. So you can see here the exercising group had a really large improvement in their strength in the first 2 years. And they followed these women for 10 years. So they didn't necessarily exercise after the first 2 years, but 10 years later, the women still had stronger muscle strength in their back, and importantly, they had fewer vertebral fractures compared to the women that didn't exercise. Now, I'm not recommending you all go and buy these little backpacks and start doing back extension exercises, but I'm just trying to highlight the point that if you do very targeted and specific exercises, you can get some very real, clinically important benefits than if you just do a generic type program. Again, here's some examples of the types of exercises we include in many of our programs, which many older adults have undertaken. And so I guess my point to highlight is you'll note that many of the exercises are done. And so I guess my point to highlight is you'll note that many of the exercises are done standing or with different types of equipment, Swiss balls, pulleys, dumbbells, even TheraBands. We try to encourage people to do their exercises in these standing or other functionally relevant type movements because it might also have functional benefits. So obviously if you do all your exercises seated on a machine, it might improve your strength, but is it going to improve your function? So you can sort of kill two birds with the one stone if you mix up your exercises and think logically about them in terms of it might improve your strength, in bone density and functional outputs. One thing just to be wary of, excuse me, hopefully I can go back, I won't go back, but those overhead exercises, just be a little bit wary of because some people have rotator cuff problems, which are the muscles in your back, particularly a lot of older adults once they start doing resistance training. So just be careful of lifting weights over your head. Now, just on with regard to falls, we know that when that there's been a number of studies looking at why people fall over. And one of the most frequent causes of falling is incorrect weight shifting. And so incorrect weight shifting means you basically can't move your foot or shift it quickly enough to gain balance and stop yourself falling over. And part of the issue here is related to your movement speed and your muscle power. So we often talk about muscle strength. That's just how strong you are. Muscle power is how quickly you can move your limbs. It's sort of the force times velocity. And that is really important for reducing the risk of having a fall. Yet traditionally, when we do a lot of resistance training programs, we are told to do nice, slow and controlled movements. So in a number of studies we've been conducting over recent years, we've been looking at the influence of high velocity resistance training. It might sound a little bit scary, but essentially just means you're trying to do the push-in phase of your exercise quickly. So when you do your, for example, a squat, for example, where you go down and up, you don't just do it in a slow control movement. We try to get you to do the lifting phase as quick as possible. So you're training your limbs to move quickly. And again, here's some examples of a study which looked at the effects of resistance training where they did people lifted heavy weights compared to if they lifted light weights. And one of the advantages of high velocity resistance training, so moving your legs quickly, is that it can result in similar benefits to functional performance whether you use a heavy load or a light load. And so there was really no difference in this particular study. Even though these guys lifted almost double the weight, their improvements were very similar compared to lifting a lighter weight. So that's, for many of you who might be concerned about lifting heavier weights, encouraging or performing high velocity exercises might be particularly beneficial in terms of not only your muscle strength, your muscle mass, and maybe bone density, but function as well. So here's another study that we've done recently called the Osteocytes Strong Bones for Life study. This was a community-based program we ran within the western suburbs of Melbourne a number of years ago, and it really incorporated all the principles I've just discussed. So it was a multimodal program looking at different, combining all these types of exercise together in the community to see if it could be done by people like yourselves who might be going to a gym as an evidence-based program to improve your bone density, your muscle mass, your muscle strength, your function as well. And so this is what the program looked like. We did resistance training, including high velocity resistance training. We developed all these resources and manuals, which included videos for the trainers in particular, so we could teach them properly to prescribe the exercises. It included weight-bearing exercises. So all they did in their exercise program was about 2 to 3 exercises of these weight-bearing impact exercises, only 10 to 20 jumps and a couple of 3 sets. And then we introduced all these challenging balance and mobility exercises. So it was a multimodal program. Half the people exercised, half didn't, and this is what we found. So again, it was an 18-month study. The purple bars represent those that exercise. The green bars are those that didn't exercise. And so if you look at the bone density at the spine or the hip, the exercise program maintained or improved their bone density compared to those that didn't exercise. And you'll see that the improvements in bone density are not really large. Most studies see sort of 1 to 3% improvements in bone density. Now you might think, that's not a great benefit for all the work I put in, but remember that you might lose bone density by 1 or 0.5% or 2%, depending on your age and menopausal status, per year. So over 2 or 3 years, you might have lost 3 or 4% of your bone density, whereas if you exercise, you maintain or increase your bone density, the difference over a number of years might be 5%. So remember, it's not all just about bone. So in our study, importantly in this study, we showed that not only did we improve bone density, but we improved their functional performance, their sit-to-stand time, their walking speed, and this 4-square test, which is a measure of mobility. And we did some other tests as well where we showed that it improved their power, improved their muscle strength. So the program was effective. The people who enrolled in the program really enjoyed it. And this study did get some additional funding as a community-based program, although the government hasn't continued to fund it more recently. So we're trying to work on how we can roll this out and make it readily available to more and more people. Importantly, some of you may be a little bit concerned that if you undertake the jumping exercises, is it going to be harmful to your joints? So some of you may have osteoarthritis or concerned about joint health or knee pain. Again, we took a whole lot of MRI scans to look at the effects of this exercise program on joint health. And as you can see here, in the exercise versus the control group, there was really no difference in those that lost cartilage. And this is typically what most people see. You lose about 1 to 2% of your cartilage volume. There was no difference between the groups. So here are my recommendations for bone health. We know that weight-bearing exercise and multidirectional functional activities are really good for your bones. And that should form the basis of any exercise program in addition to resistance training. And once you've done a little bit of resistance training, we recommend that you try to progress to, especially to the lower limb exercises, to some high velocity power training. It's important to make sure you target the hips near the muscles attached to the hip and the spine. Okay, so you might want to have multiple exercises around those regions. We know you don't need to do a lot of impact loading, so for weight-bearing exercises, it might be 3 to 4 or 5 times per week. Progressive resistance training, the general recommendations are at least twice per week. And you can see, in terms of the intensity, moderate, odd, or diverse loads are important, so you don't have to do really high-impact loading. Do loads which are sort of that vary in direction and magnitude. The resistance training, generally we find that the high intensity is better, but the key principle is it has to be progressive. It's got to get challenging over time. And in terms of the duration, you can see you don't need a lot of jumps, and typically weight-bearing, a whole program might be anywhere between sort of 30 to 45 minutes for musculoskeletal health. You may ask questions about other types of exercise which many of you perhaps enjoy, things like Tai Chi, yoga, and Pilates. Look, there is some evidence that these types of exercise might be good for falls prevention, but the evidence, and I must say it's rather limited, suggests that they don't really have any beneficial effects on bone density. And for yoga in particular, you just need to be careful with certain types of yoga movements. Anywhere there's sort of forward flexion where you're leaning forward, just be a little bit careful, because some people who have low vertebral or spine bone density, they can increase their risk of having a fracture when you're leaning forward. So again, just be a little bit wary with that type of activities, but generally they're good for sort of functional outcomes, but not so much bone density. Some of you may have seen these vibrating platforms where you stand on them and they give you a good shake. Look, there's a whole host of platforms available in the market. Gyms have these platforms, nursing homes have these platforms, and they vary markedly in sort of what they can do. So typically, most of the evidence is showing that these vibrating platforms don't have a lot of beneficial effects in terms of bone density or functional outcomes. However, there was this one very large trial which went for 18 months in a large number of elderly women, and they did show exercising on these platforms did reduce their risk of having a fall and fracture and improved various functional measures. So I think with an appropriately prescribed program on the platform, you might get some benefits, but I think just simply standing on the platform and depending on which one you've got, you can't expect it really to have lead to significant improvements in functional outcomes. Just another word of warning with regard to weight loss programs. So obviously for some people, an emphasis on an exercise program is to help them lose weight as well, or they might be on a dietary restriction or caloric restriction program to lose weight. We do know that if you lose weight and you don't exercise, you tend to lose bone mineral density and you tend to lose your muscle mass as well. And so this was a study which looked at the effects of exercise alone or exercise with diet on bone and muscle. And you can see here, just doing exercise alone improved your muscle mass and improved your bone density. But if you did exercise and diet, the responses were somewhat blunted. They weren't as bad as diet alone, but they weren't as probably optimal as just doing exercise. So I'm a little bit cautious about recommending substantial weight loss for certain people who might not need a lot of weight loss, and they're concerned more about losing their fat. I think we should be concerned more about maintaining our muscle, because muscle is metabolically much more active than fat. It's important for functional outcomes, important for maintaining your independence, so we want to maintain our muscle in particular. What about for very elderly or frail people? What are the exercise recommendations? So for many people, if we look at the risk factors for falls, you can see the top 3 or 4 risk factors are muscle weakness, deficits in gait, and balance. And so we need programs which are going to specifically help improve our strength, our muscle power, remember our ability to move our legs quickly, and our gait and balance. And so what actually works? So for very high risk groups who might have already had a fracture, or who might have osteoporosis, are concerned about exercise, these are the types of exercises that you might want to start with. And you can see most of these are achievable. And I've put some little guidelines down the side here, or some caveats. You just need to be careful with certain types of exercises. As I mentioned, forward flexion activities, learning how to, say put on ankle weights or pick up something from the ground, where you might have to bend over. There's just some tips and tricks about making sure you have correct posture initially when you're lifting groceries out of the back of the car, for example, and then undertaking these sort of introductory type exercises. It's a good starting block for sort of the high-risk person. In terms of falls prevention, what actually works the best? Now, there's multiple programs and multiple studies out there showing that exercise reduces your risk of having a fall, and that is true. It reduces your risk by about 20 to 30%, but some types of exercises are better than others. So this, again, was a large study, which is a summary of a whole host of studies, and you can see they looked at different types of exercise. They looked at resistance training, they looked at balance, they looked at endurance training, stretching, or walking, and what you see, basically, is that the most effective programs were those that included challenging balance activities, and it reduced your risk of having a fall by about 25 to 30, by about 25%. Okay, and over here you can see, as long as you did about 2 hours per week for 25 weeks, it tended to reduce your risk of having a fall. So you can see here that resistance training by itself didn't really have a beneficial effect on reducing falls. And that's perhaps not surprising, because remember, most resistance training programs, people are seated, they're in machines, and then trying to improve their muscle strength. They're actually not really focusing on improving their movement speed or functional outcomes. So that's why we think power training is particularly important. Here's some examples of some challenging balance exercises that we've done in our various programs. So things like moving your center of mass, changing your base of support. Again, you can do these while the kettle is boiling if you wanted to. Leaning, reaching, dynamic balance. And it's really up to your imagination. Obviously, if you're sort of a bit unbalanced or unsteady, is probably perhaps more the word, stand next to a wall just to make sure if you're doing some of these balance exercises, you can grab the wall in case you go beyond your sort of normal balance to stop yourself falling. But again, here's some very easy exercises that many people can undertake. The other important point to bear in mind is that core stability or core strength is very important. We know that if you've got a weak core, that can increase your risk of having a fall as well. So again, you just need to be careful with certain types of exercises for the high-risk group. So you don't really want to do these sit-up activities or these spinal twisting activities. So you just modify the exercise accordingly. But you can see these simple types of exercises are very good for improving core muscle strength. Just to highlight some other very simple activities, here was a study which looked at the effects of doing a very structured program in the gym or just doing everyday activities at home. So you can see raising your legs at home, sitting up from a chair, climbing up some steps. And so they looked at the effectiveness of this lifestyle approach versus this simple structured program or a sham exercise. And if you look at the benefits here in reducing your risk of having a fall, simple lifestyle approach was more effective at reducing falls than this structured exercise program. So you don't necessarily have to go to a gym. You can do certain types of activities at home. The other important point to bear in mind for some of you which might like social activities is dual task functional training. So dual task training basically means you're doing an exercise with an additional cognitive or motor task. So dancing is a perfect example. You're trying to listen to the music, you're still trying to exercise, and so it's like a cognitive and motor task in addition to your exercise. And that's really important because we know many people fall over because they can't dual task. They can't carry the groceries as well as walk over the footpath or the curb as well. So dual task training is really good, and this particular study showed that this dual task sort of music-based exercise program reduced the risk of falls by 50% compared to those that didn't do exercise. So we've been exploring some dual task activities in our exercise programs as well, and people in retirement villages. You can see here's some examples of dual tasking. So this is like you carrying the washing from the line and trying to step over various aspects in your home as well. So again, some multi-stepping tasks when the arrows might light up, doing exercise with the partner. These are examples of dual task activities, and they're often more enjoyable than perhaps exercising by yourself. The other important, I guess, evolution has been technology and what role that might have in improving your functional outcomes to reduce your risk of having a fall. So we see the Wii sort of fit type exercises, and there's been a number of interesting studies in older adults where they've done using this technology and shown that, look, they often enjoy that type of activity in a group setting, and it can also improve functional outcomes as well. So here are my recommendations for falls prevention. There's no one-size-fits-all. Everyone is going to be different in terms of where they start for a falls prevention program, in terms of some people are going to have sort of adequate function and balance, and other people are going to be more impaired. But we know that challenging balance activities are particularly effective if you focus on these three aspects. We know you do need to do it relatively regular to get the greatest benefits. A group or home-based setting is fine. You don't necessarily need to go to a structured gym-based program. Just a word of warning about walking, I guess. Many of the programs show that if they included walking with their balance activities, they tend to be less effective. But ultimately, the goal for any type of exercise is to get people out and about and walking and maintaining their independence much more often. So the recommendation really is, if you're a little bit unsteady, don't start with a walking program. Do balance and mobility type activities, and then you might introduce walking later on. And same with resistance training. In combination with balance, it's most effective for functional outcomes rather than just resistance training alone. And finally, I just want to finish off about what I call non-exercise physical activity, where you're not actually thinking about being active or engaging in any exercise at all, but just doing things throughout the day to stop yourself sitting. And I'm sure many of you have heard the news about sitting is the new smoking, and it's a new health hazard. And there is some really strong emerging evidence showing that prolonged periods of sitting are actually bad for your health, that's your cardiometabolic health, but also for your function as well. And just to illustrate this point, we did a study looking at whole of older adults and looked at how much they sat, and we found that those that sat the longest had a greater risk of having sarcopenia, so low muscle mass, impaired muscle function, compared to those that regularly got up and down and didn't have great long periods of sitting. And just to highlight this point further, there's a very nice study which was done in over 1 million people, or was a whole host of studies, which they combined them all together, but it included more than 1 million people, and they looked at the association between sitting and your risk of dying, in addition to how much physical activity you had. So if you look down the bottom here, if you did 60 to 75 minutes of physical activity, it doesn't matter how long you sat, you weren't at increased risk of dying. So you had to do quite a lot of activity, but if you sat for 8 hours a day, you had a slightly increased risk of dying, but it wasn't really significantly different from the other groups. But if you look down here, 25 to 30 minutes of physical activity, and that's the current recommendations per day that the government recommends. You can see here, the longer you sat, the greater your risk of death. And so, again, I suggest that we, as a starting point, that we try to encourage you to stop sitting for prolonged periods of time and just get out of your chair on a regular basis, because it might have some functional benefits as well. So on that note, I suggest that you all get up, get out, and don't sit for prolonged periods of time. And thank you for listening. I'm happy to take any questions.
Great. Thanks for a very informative and interesting presentation, Rob. It's definitely coming across that exercise is the #1 medicine, and obviously not just for osteoporosis, but for the prevention of many chronic conditions. We have had a question a bit earlier from someone who couldn't log on live tonight. Her question is that she has had 7 compression fractures this year, and she is wondering who is the best person to advise someone with osteoporosis who has had multiple fractures on the best methods of exercise. So where can she go to get help if she wants a little bit more direction?
Sure. I think there's 2 options for I guess I classify her as a high-risk patient. Physiotherapists are certainly one option. If she's still in that phase of pain and loss of mobility, the physiotherapist is certainly a good option. From the physiotherapist, she then could progress to what we call an accredited exercise physiologist, and there's a website which is Exercise and Sports Science Australia, or ESSA, where if you go online, I don't have the details with me, but it's ESSA. There's a little link where it says find an exercise physiologist, and you type in your postcode, and all the exercise physiologists close to where you live will pop up, and you can potentially make an appointment to see them. And again, you can talk to your doctor about accredited exercise physiologists as well, because they fit under the enhanced care plan scheme for people with chronic diseases, and you can go and get up to 5 allied health visits, and that includes an exercise physiologist. So you can get a free assessment, and they can start to develop an exercise program for you as well.
Yeah, and I think that's something that comes up quite often, is that those that have had fractures are fearful of exercise and putting themselves in an environment where they may have another fracture, and that's obviously it's a bit of the opposite, that you need to do more, but in a safe and well sort of structured environment.
Absolutely.
We have had a question from Wendy asking if there's any truth in the acid-alkaline diet. So if there's less acid, means the body doesn't have to take calcium from the bones. Do you have any comments on that? Yeah,
look, that's a very controversial area, and I guess 10 or 15 years ago there was a lot of concern about potentially this acid diet being negative to bone health. But the reality is there's more recent evidence is really not stacking up to support that it really has a negative effect on your bone health. And this was driven largely by protein intake, for example. So people who had high protein diets, they were concerned that that was going to increase this or push the balance towards an acidic-based diet and therefore contribute to bone loss. But it's actually the opposite. We've done a complete 360, and it's the opposite. And we know now that protein is really important for bone. It's the building blocks for bone as well, but it's really important for muscle as well. So I would suggest that I wouldn't be too concerned about this acid alkaline-based diet, and many people are not going to get to such a state where the acid, if they were to have a diet that might be more acidic, is going to lead to any detrimental effects on bone.
Yep, that makes sense. Grace is also saying, so Grace is an osteoporosis nurse at Monash. Any community exercise program you recommend for our patients that visit their clinic?
Look, thanks, Grace. It's an interesting question, which I'd like to say that we've got multiple community-based programs out and available to the people in the real world. Unfortunately, there isn't, as far as I know at this stage, there's no specific program I can recommend you to. Our osteocytes program did get rolled out in multiple states in the east coast of Australia, but that was initial trial pilot implementation. So some gyms and facilities are still running it, I think in Geelong and up in Sydney and Canberra, but it's not widespread at the moment. Again, as I mentioned, it was sort of something, but it's not widespread at the moment. Again, as I mentioned, it was sort of something we applied to the government to make this an ongoing process. And currently I'm exploring different avenues to try to maybe upskill more trainers so they can be sort of accredited osteocytes trainers and therefore deliver evidence-based program within their own facilities. Bearing in mind that, you know, a lot of gyms and facilities have sort of programs which are okay and have components, say, of the osteocytes program, but don't offer all three components. And so, look, I think if you've got some knowledge about osteoporosis and there's some local gyms, you could potentially talk to the trainers at the gym and ask them what they're actually offering and seeing whether their programs sort of meet the criteria with some of the concepts I discussed today. And so, because some of them might be still fine to sort of fit under evidence-based, bone-friendly type programs.
Great. All right. Well, if there aren't any other questions, feel free to type them in now if you do have any more. Wendy, this seminar will be available, so we've recorded this presentation, and you will also get a copy of the recording and the slides, Rob's slides as well. One last question, Carmel, in older adults, I would expect pelvic floor issues would need to be taken into consideration and that low impact weight bearing would be essential. Any comments on that regarding programs? I work with the Living Longer, Living Stronger program and balance and resistance. Any comments on that, Rob? Yep,
so thank you, Carmel. That is an excellent point, and I do neglect to, in many of my talks, to discuss this issue, but it is a serious and common problem, obviously, for many women. And in many of our programs, we do have an emphasis on pelvic floor exercises because it does limit them to do various jumping and weight-bearing impact exercises. So it's a really crucial element that we need to incorporate in pretty much most of our exercise programs, especially if we're thinking about these weight-bearing exercises. So excellent point, and thanks for reminding me on that.
Fantastic. Thanks, Carmel. So once again, a sincere thank you to you, Rob, for your presentation tonight. I know that I've taken some interesting points to think about. And I also want to thank everyone who's joined on live tonight. Thank you once again for joining. And I'll also mention, we do have a free helpline at Move Muscle, Bone and Joint Health, 1-800-263-265, if you'd like to speak to one of our nurses as well. And can I also please remind you, if you could take a moment at the end of the presentation to complete the quick survey at the end, we'd really enjoy having a look at your feedback and sort of helping us plan our future webinars. So thank you all once again. Thanks, Rob, and good night.
Thank you.